Okay. This is a talk I've given before, and I think Claire Richmond gave me the title, which is a bit, because honestly, that's what's happening inside my mind. It's like, dear donuts, is Jackie cooking the barbecue? So perhaps a more appropriate talk would be, we'll talk about how aeromedical control works, and we'll talk a bit about clinical triage. And because I like putting up old photographs, but also because what we've done in the past informs what we do now, and which in turn informs what we do in the future, I'll talk a little bit about the history of how we've got to where we are today with the service we have. So there's been a helicopter doing rescue work in Sydney for 50 odd years. The first helicopter mission involving New South Wales ambulance paramedics happened in Newcastle in 1980. And since the early to mid 80s, there's been regular or irregular initially, doctor and paramedic staffing on helicopters in Sydney. Initially the Surf Life Saving helicopter, and then Care Flight was set up in the west of Sydney in 1986. And from 1988, there were paramedics permanently assigned to these helicopters in Sydney as a permanent assignment, and one of them, Bob Lyle, is still with us, although on leave at the moment. I quite like the jumpsuits, Mo's and black gloves look from the early 80s. It's got something going for it. In the bottom corner, the top picture, the top right, is actually the first into-hospital transfer done by New South Wales ambulance paramedics in 1980. Jumping in the Surf helicopter up in Newcastle. We never used the crop dusting helicopter, but with keen eyes, you might recognise a young Marty Pearce who's jumped in the back of a helicopter as a first-year paramedic out at Moree to transport a critically injured patient back to Moree Hospital for definitive care. And in the other photo, you might recognise that Matt Scott does not look a day older than he did 30 years ago. And we've got Bob Lyle and Paul Koenig, who are still with us. Bob Lyle more appropriately in his aviators, which he appeared to wear constantly for about 20 years. Feathers there showing that, on the right, showing that a comb over does not stand in the way of being an ambulance legend. Leon Cribb in the back of the middle worked on the Lismore helicopter until 2 years ago, so he was, continuously on helicopter operations for over 30 years. So from the late 80s, 90s, early 2000s, we had two community helicopter providers, one in the east of Sydney and one in the west, Care Flight and Lifesaver. The operations they did were evolving more to what we were doing now. Some big jobs. That's a young Tim Thistleton in a baby blue jacket, with the doctor on that job is Andrew Pearce, who's the medical director at MedStar in Adelaide. So on that job, a guy's come off a motorbike in the bush out beyond Lithgow, critically injured, and they've gone in on the back of other guys' motorbikes to RSI him, put him on a ute and drive him out. Some of the processes we did were slightly different. That's Marty using an early edition of an iPad for a bit of recreation en route. The doctors used to do the ARV, so that's me doing a strop lift of probably Wilco in training. We used a tagline on the ARV then. Young Wilco on the Old St George helipad with a nice pose by the door. There was a lot less downwash on a BK because that's using a camera rather than a phone to take selfies while we're on the hook, while we're doing a cable tensioning exercise and looking for whales. I'm not sure that'd pass muster today. So from 2007, we went to a single Sydney helicopter base, as well as having the rapid response Care Flight helicopter based at Westmead at that stage in the head injury retrieval trial. There are regional bases where there are now, so Canberra, Wollongong, Orange, Newcastle, Tamworth and Lismore, but we didn't have 24-hour doctor and paramedic staffing at all those bases until 2014, so there was intermittent staffing for the decade before that. Since 2017, on the current contract, we've gone to a single helicopter type and with a standard fit out across the state and just about standard equipment across the state. And one of the really big steps forward is to have centralised paramedic training and oversight. So whatever happens through the state, the paramedics work on a very similar page. The doctors less so to a degree, but we're moving there with some statewide training assurance to make sure all our retrieval providers are trained in a similar manner. A few photos from as we move close to the future. We've started on 412s in 2007. That's Mark Gordon showing the benefit of his early work as a male model in the top photo. We had a 145 and a 139, so we went to 139s only in 2017. So as helicopter operations evolved, so has the way we tasked term has changed. Back in the 80s and early 90s, it was a mix of referring facilities, contacting ambulance or ringing either of the community helicopter operators directly. So CareFlight or Lifesaver would just get rung by a hospital and say, can you move a patient to another hospital? Pre-hospital operations would be tasked through a variety of things. SURF would do it by actually SURF Life-Saving Radio would often contact us for jobs. Some of it would come through ambulance. It came through all manner of mechanisms. But since 1997, we've had a central control and tasking of all aeromedical operations in New South Wales. It was initially called the Medical Retrieval Unit and still called the MRU. Even on CAD, you see it often referred to as the MRU, which is essentially a historical term for the control centre. It was initially co-located at Mascot with Air Ambulance. So the room we now use for writing up our case sheets was the old ACC. Then we went to St George Hospital till they built their new clinical services building. Then we moved to Everleigh, or the Sydney Ambulance Centre, where Aeromedical Control sits on top of Sydney Control, which sits on top of Redfern Ambulance Station. And supposedly next year we're going to move out to Homebush. I think this is a photo from the old base at Mascot, but it might be St George. In the background, Linda Mount Stephen still works there as one of the ACC educators. So just like in our operations here, there's sort of some consistency of operators who's worked through the system for a long time. As I said, now we're in Everleigh. There's about 15,000 missions a year tasked out of the ACC, and the bulk of that is fixed wing flight nurse only missions. Okay, so about 2/3 of it is that. There's about 3,000, somewhere between 3,300 and 3,500 into hospital medical retrievals every year. 40% of them or so done out of this base. And then Newcastle does about 40% of what we do. Canberra does a bit less than them, and all the other bases do about the same. So who's in the room? There's a number of different people. At night, there might be down to as few as 4 staff. During the day, there might be 8 or 9 people in there. So most of the time, we're speaking to Aeromedical Control Centre officers. The bulk of them are from a paramedic background. There's one who comes from a flight nurse background, but the important thing is they're clinicians. If you ring 000, your call is primarily taken by a control centre officer who is considered as a civilian. They've done a short course, they've got no clinical background. Whereas having clinicians involved in the call taking we've found very helpful for, picking up when we need to escalate care and providing insight into the patient's care. So it's been a really useful thing to us to have clinicians involved every step of the way. The Echoes take bookings primarily of the fixed wing work. They do some assessment of priority, which we'll talk about. And there's a fair bit which happens in a fixed wing mission around flight planning, fuel, ambulances, etc., which is handled by the Echoes. And because there's not many people in the room and the workload can surge, at times the Echoes will be assisting the clinical coordinators, who is a nurse coordinator, and the RLTC, who I've written down incorrectly, at times of increased workload. So the RLTC is an Echo, who's extra training basically to work in helicopter dispatch, primarily for pre-hospital jobs. They scan the CAD, the 000 system for the entire state, to identify jobs that will either benefit from a medical team for clinical reasons or potentially for a helicopter for access reasons. They task the helicopters, they do all the radio calls. There's Marksy back in the day. That's probably 2004, 2005, when we first started doing the first RLTC was really as part of the care flight head injury retrieval trial. So we used to, those of us who worked on that, we would be using CAD to identify potential jobs, which could then be randomised to see if we needed to see a medical team to it. We did that both by looking at information on CAD and by ringing back, as I presume Marksy's doing here. We weren't the first people to do this. There'd been, London HEMS had been doing this for 10 or 15 years before us. But it was the first that we'd done it in New South Wales. Certainly initially we realised we overcalled a lot of things and learnt there's a skill to identifying when, because you want to overcall to a degree, but our hit rate of taskings to jobs was less than 30% initially, and you need to be better than that. This is the back of Bob Lyle's head when we first had the RLTC in at Everleigh. The setup today is pretty similar to that, a bunch of screens looking at CAD from across the state. The whiteboard in front of you is the helicopter status board, which has now moved online, you know, rather than magnets and a whiteboard. But otherwise, the setup is pretty similar. So clinical coordinators, for about a decade, we've had nurses in the Aeromedical Control Centre, and they're senior nurses, all from a critical care background, some with a flight nurse background as well. And they are taking clinical details and assigning clinical priorities essentially to all those fixed wing jobs that happen. They're involved in the retrievals, and their involvement in the retrievals is to chase clinical information, do some ICU bed finding. But most of their work is around the flight nurse only jobs. That keeps them really busy. And then we come to the State Retrieval Consultants, of which I am one. There's about 20, 25 of us with varying fractions. Like out here, we're primarily emergency physicians, although there's a few anaesthetists and a few intensivists. We have a combination of people based either in Sydney or regionally. Having regionally based people has some benefit in that we don't want to be a completely Sydney-centric service as we're a statewide service. And having guys based in Lismore and based in Dubbo and previously based in Canberra has been helpful to getting a decent dialogue across the entire state. But it also comes with challenges because they do their shifts remotely, and it certainly works better if you're in the room talking to the other people involved in tasking and job identification face-to-face. All of the state retrieval consultants you'll talk to will have significant retrieval experience, although some are no longer doing operational retrieval. Some of them are here, some of them are at Tamworth and Newcastle, and some are with the RFDS. So there's people working in Lismore, people working in different places. So when you're speaking to someone, they understand the work. There's a number of ways, similarly to here where we do monthly clinical governance day, we do clinical governance meetings. With a small group, you can have quite collegiate and intimate, I guess, job discussions, which is good. And I'll talk about it a little bit more, but because you can't protocolise this stuff, but we do want to have a similar approach to similar jobs. So the role of the state retrieval consultant is essentially to coordinate and prioritise inter-hospital missions. So their role is primarily around inter-hospital stuff. That said, especially for those of us who are in the room rather than the regional guys, is you have some input into pre-hospital tasking. There'll be a back and forth dialogue with the RLTC about whether, you know, this job would benefit from a medical team. A lot of it's open and shut trauma and it doesn't need that discussion. But for more borderline cases or where the natural flow of that patient will be to the wrong facility, we'll have a discussion about, you know, where the extra, what can we add to that job. We provide clinical advice to referring clinicians. You know, within the Sydney basin, most of the places which refer have senior referring clinicians, but outside of Sydney, you're often dealing with GPs who aren't used to critical care and talking them through the management of a sick patient who's going to get retrieved. We provide clinical advice to retrieval clinicians. Out of the Sydney base, a lot of that's done by the DRC, but there's overlap across the state and overlap even with Sydney of how we do that. New South Wales Ambulance has a paramedic advice line, which is a bit dysfunctional. I think it's a fair assessment. There'll be times when an ICP on the road will be ringing up and a P1 will be staffing the advice line and just will read out the P's and P's to them, which is not really fulfilling the function that the road ICPs require. And so there will be some occasions where ICPs on road will ring to talk to the State Retrieval Consultant because they're hoping to get higher level clinical advice from someone who understands their workplace. That's ad hoc, I guess, and unofficial, but happens on every few day basis. And we do some ICU bed finding for higher priority missions where the lower priority, you can still be really sick, but the lower priority ones, the responsibility for bed finding lies within the LHDs, but we will find it for the sicker patients. And so why would someone do this job? For me, the reason I do it is, and I've done it for 16, 17 years, is that a service is only as good as what you get tasked to. And we all spend a lot of time complaining about the tasking, and we always have. And I think if you're going to complain about it, you should contribute to fixing it. So that was why I became involved, and I hope over the years our tasking has improved. It's also like the work here, it's enjoyable. We spend a bit of downtime here with people you like, and I spend downtime at the ACC with people I like. It's certainly, you can be very busy, but it's a nice respite from a challenging day in emergency. So we've, as well as State Retrieval Consultants, we've got some State Retrieval Fellows. The reason we have them is it was kind of a role developed through necessity because we couldn't recruit enough State Retrieval Consultants. And it's funny, when I came to retrieval as a registrar 23 years ago, they couldn't recruit enough registrars. It was a job where you struggled to fill the positions. And even as long as 15 or 16 years ago, we give every person who applied for a staff specialist job a staff specialist job because there just wasn't the enthusiasm for the role that there is now. In 2022, I think we have got to a point where all facets of aeromedical jobs are a lot more popular, and we're getting more applicants for any job. All the ACO roles are oversubscribed when they get advertised, the clinical consultant jobs, clinical coordinator jobs. But when we developed the State Retrieval Fellow role, we were struggling to fill SRC roles. So we thought, let's see how we can grow our own. And part of that was, it was also clear that there's certain aspects of the job that don't come easily to a new consultant. So those new consultants with retrieval experience we've employed as fellows. And over the course of the year, they've got sort of increasing independence in their decision making. And most of the challenges around providing remote advice in really critically ill situations to a GP, which most people in their training as an emergency physician or an anaesthetist have limited experience with giving remote advice. And also at times there's challenging discussions with other senior clinicians about what has to or shouldn't happen with a patient. This has been a really successful program for us. Basically, every person who's been a State Retrieval Fellow has progressed to being offered a State Retrieval Consultant position. So at some stage, we're not going to have any FTE left to continue to employ fellows. But it's worked really well for us over the last 4 or 5 years. As I said, there's a bunch of regional retrieval services and they do their own coordination. There are some pros of coordinating things locally in that you establish relationships with the local facilities which retrieve to where you are. The Canberra guys probably do it best. So they've got really good relationships with the smaller facilities on the south coast and are very good at getting those patients in through their doors. The other services all have varying problems of using the coordinating doctor and the flying doctor being the same person, having someone coordinating who's working on the floor of ICU or on the floor of ED. And there's challenges which come with that. And I suspect at some stage over the next 4 or 5 years, we'll probably see a change in the way the regional services are coordinated. There's also 2 critical care advice services, one V-Care, which covers the Greater West, and the Murrumbidgee Critical Care Advice Line, which works out of Wagga and covers west from there. And the idea of those services is they're locally based clinicians who provide advice to smaller facilities in those areas, often for conditions which are below the level of what needs retrieval, you know, chest pain, abdominal pain, stuff like that. They do make for a challenging is probably too strong a word, but a interaction where you have to make it very clear who's going to continue to provide clinical advice, whether it's the V-Care consultant or the retrieval consultant, and whether as the retrieval we're just going to take over the logistic running of the job. And we tend to default to letting the V-Care continue to run it, but that doesn't always work well, and more we're thinking for the sicker patients we should be taking over the coordination of that job, which usually V-Care are happy to do. So how we used to do tasking was, back in the days of when the MAU was at Mascot and then at St George, was someone rang up. You rang up from a referring facility and said, I've got a patient to go somewhere. And if the patient's destination was in the east, it'd get sent to the next doctor on for Lifesaver. And if the patient's destination was in the west, it would get sent to the next doctor on for Careflight. And the phone call would go through, and as the retrieval registrar, I would take the phone call, I would provide advice to the referring clinician, and then I'd head out and do the job. We recognise there are a whole bunch of holes in that thing, in that one, the most obvious one is you stop being able to provide advice when you're on the way to the scene. So you can't provide continued advice to a referring clinician struggling with a very sick patient. Secondly, there was an inconsistent amount of time the calls would take. You'd have people sometimes sitting on the phone for an hour providing advice when they really needed to be on the way. There's a bit of self-interest, which either deliberately or subconsciously came into play. You know, I don't want to do jobs on night shift. I do want to do jobs on day shift. Maybe that influences my decision to go and do a job or not. And we had back then a few ACC consultants, and they were basically involved if there were no more assets or no more beds. And generally you'd get a phone call when every asset in the state's out and a car's rolled over in Burke and there's 4 people injured, and someone rings you up and says, who can we divert? And you go, well, what's everyone doing? And they go, I don't know. And so you'd have to ring all the referring hospitals again, work out what they were going for, and unpick it. So we thought we could come up with this classy thing called triage, where we try and work out where we'd send the assets to the patients who most need it. And there's a bunch of factors which affect the urgency of transfer. And when we brought this in, to me it seems obvious, but it took, as a group, a little bit of time to get our understanding of the fact that the patient's clinical condition is important, but it's not the most important thing. Equally important is where the patient is with that clinical condition, because a patient in Blacktown in septic shock is very different from a patient in Wellington with septic shock. So we have to triage them differently depending on where they are. And that's not just around the capabilities of the referring facility, but also the clinicians who is looking after them, because we all know there's days where you get managed much better at one hospital than at the same hospital the next day, solely because of the team that's on to manage you. And of course, the reason why you're going, you know, there's more urgency around moving someone for an expanding extradural than there is for someone with urinary sepsis. So what we do, we developed about a decade ago a system where all patients are assigned a clinical priority, which goes 1 highest priority to 5 lowest priority. For retrievals, or all retrievals and all potential retrievals, this priority is assigned by the SRC. The jobs are flagged there. Some of it's if you've ever rung the ACC number, you press 1 if you want to do a retrieval and 2 if you want to do a paediatric retrieval. So some of it is flagged by the referring facility, and most of the time they do that pretty well. There'll be about 20% of jobs which are flagged as a retrieval aren't done as a retrieval, but they're pretty sick, and it's good to have SRC oversight of those jobs. There'll be a smaller percentage of jobs who are just booked as a standard job, where this is where having clinicians involved in the ACC at every step is really important. They get picked up as, hang on, there's something more to this job. And that we collect OBS on everyone, so OBS outside the flags mean they get triggered to the State Retrieval Consultant. And if there's anything else that just smells bad, it comes to you. And as I talked about, we're the default provider of clinical advice. So in general, that means the SRC is going to be talking the referring clinician through the initial resus and stuff that they're providing for the critically ill patient they're talking about. This is generally done by phone. We've now got, Cara will be excited to know, a statewide web-based overhead camera network, which covers about 2/3 of the state, which is a big plus. We used to have a whole lot of firewalls between various LHDs, but we're getting closer to having the ability to look at patients throughout the state. We can now look at all their we've been able to look at all their X-rays for a few years, which has been really helpful. And some stage in probably the next half a century, we'll get statewide EMR and be able to read their notes, which would be nice. The priorities come with different dispatch times, which you can see there. Priority 4s are, it's Wednesday today, someone's having a cardiac cath on Friday with stable angina. That's a priority 4. When we don't do them, they really don't happen in retrieval. That's something that happens in fixed wing world. The other priorities do. There's a priority 5 happening at the moment of someone who's got failed stroke, clot retrieval who remains intubated and who's going back to Nowra. That's a priority 5. It's a backload. An important thing which we often seems to be forgotten about here is the time frames are around dispatch, not response. We've got separate response times. Essentially, we get a job, we're meant to walk straight out on the job. It doesn't matter if the job's a P1 or a P3, we're meant to head out on it. Some sanity needs to prevail around meals and things like that to make sure you're fed and watered. But at the end of the day, you get a job, you go and do the job. The priorities allow the control centre to juggle assets to make sure they respond in the appropriate time. We try not to task anything below a P2 after midnight, just bearing in mind they're less, by definition, less urgent jobs, and we know we're more likely to make errors after midnight, so we try not to do that. But at the end of the day, we can all have input into it, but the priority is the decision made by the ACC consultant. And I'll talk about, we've got some guidelines around what should be a P1 and what should be a P2. But because of the complexity of presentations, there's too many to protocolise. So you to a degree, you can have some guidelines around how you do it, and we have to put the right people in position to make the decisions and trust them to do it well. So priority 1, all pre-hospital taskings are automatically tasked as a P1. If it involves difficult access, there's a separate layer of scrutiny around the helicopter duty supervisor and mission oversight to see should we be undertaking this mission. And that's working from the same principle, but basically to ensure that we undertake appropriate risk. We undertake risk appropriate when we should be undertaking it and not when we shouldn't be. With regards to in-hospital jobs or inter-hospital jobs, anything that's immediately life or limb threatening, so rescue angio, expanding extradural. And then, in my mind, if a patient is in a GP-only facility and they need a medical retrieval, so they're critically ill or injured, that patient's a P1 unless I can think of a reason why they shouldn't be a P1. You know, there may be the clinician's managing well, the patient's relatively stable, I'm able to provide them a level of support and advice, they can be a P2, but in my mind, they start as a P1. And generally, major trauma patients who are in a non-trauma centre, we know these patients have significant missed injuries and bad things happen, so we try and treat most of them as a P1. But again, if they're being, you know, if you've got a major trauma patient in Dubbo, which is a non-trauma centre, it may be well managed. It's not necessarily a P1. It may be a lower priority. Just depends on the case. Now, priority 2 is the next level down. And again, if you're a patient who is in a hospital without ICU facilities, so it's bigger than a GP-only hospital, but it's in a hospital without ICU facilities like Fairfield, that patient starts as a P2 and you look for reasons to make it something else. You know, of course, can be a P1 if it's more urgent, but you need to be really comfortable that they're being looked after well for it to go down. P3 is, you can be really sick and be a P3, but, you know, you could be someone who's in Blacktown ICU with needing to go for a higher level of care at Westmead, but you're being managed well at Westmead and you're not going for any time critical interventions. Or generally, no ICU bed transfers are prioritised as a P3. But there needs to be some nuance around that, because say you've got 3 intubated patients in Campbelltown ED and they've got no ICU beds, there's no way they can look after those 3 patients. So we have to move some of them out of there no matter what the time of day is. And at the end of the day, the direction to the SRC and the clinical coordinators is to explore how well they're getting looked after at the time. And if we're not happy with the level of patient care they're providing, we'll increase their priority. Priority 4, as I said, is for a planned procedure or appointment. And priority 5s are backload where there's no upgrade of care. So once we've got a clinical priority, once a clinical priority has been assigned, I go to whether, you know, this mission may be a fixed wing or it may be a helicopter mission. I go to whichever is the appropriate logistics person. I say, I've got a P3 mission to go from Dubbo to Sydney. And then that person should contact the helicopter provider and say, ask for an aviation risk score to do that. And the idea is we're matching clinical urgency with aviation risk, because it's not a risk-free business. It's not like it's either yes, you can do it, or no, you can't. And anytime you say yes, it's fine. It's obvious that nice sunny day to day is much safer than flying in the middle of the night when everyone's cold and wet and tired, even though you may still be able to do it. So what the aim is to only undertake a higher level of aviation risk when you've got a higher clinical need. Okay, so green means you go, red and black mean you don't, and orange and yellow mean some discussions have to take place. And the idea is that those discussions should basically explore, is there another way of doing this? Do we have to do this now? Depending on the discussion, it's the pilot may need to involve the senior contract pilot, or the State Retrieval Consultant. We've got a few of us who are State Retrieval Consultants are on their senior second on call line, where basically they're just have a mandated discussion about the needs of doing this, and there'll be some discussion with the crew. I don't think as a system we always do this really well, especially the yellow ones tend to just go, oh yeah, it's a caution, you can do it, that's a go, where there should be a discussion there, and that doesn't always happen, and we're trying to reinforce that happening better. I think when it's amber, the discussion takes place well. I don't know, other people may have feelings about that. So a few cases.
Before we go on, Neil, can I ask a question?
Wait a second for the microphone. Always a bit still at the back before you ask questions. I'm gonna
just to make you run. You might be covering this later on, Neil, but just the decision on the transport platform, what sort of input you've got sort of reassuring paramedics, for example, that it's okay for them to go without a medical retrieval team, that sort of discussion?
So if, as I said, about 20% of jobs which get called in as a retrieval, we don't do as a retrieval. And most of them get done by road paramedics, occasionally get done flight nurse only. With us a flight nurse, it's easy. We do a direct handover to the flight nurse of the job and say, these are the reasons, this is the job, this is the reason why it's not a retrieval. There's a discussion back and forth about, are you happy to do it and do you agree with that assessment? Because you don't want to send someone off to do a job they're not happy with. It doesn't function as well with doing that to road paramedics. So what we do, there's a note goes into CAD for every job, which says this job has been triaged by the State Retrieval Consultant and considered to be appropriate to be undertaken by road paramedics, and has the phone number to contact the State Retrieval Consultant. When we first started doing that, they'd always call and you'd give a handover and a discussion about it. And in general, my feeling was that once a rationale had been discussed and explained to people, they're usually happy to do it. And if they had pertinent points which I hadn't considered previously, we could revisit that decision making or decide to still do it with some support. I find people call in less over the last couple of years since we've done that, whether that's because people have just got used to seeing that message on CAD and think, oh yeah, that means it's been looked at, I'm happy, or it just means people don't have time or people don't notice it, I don't know.
You find that teams will get down there and then say, nah, not happy, and then sort of comes back to a retrieval?
It doesn't happen much, actually. So the question was, do we find that a paramedic or a flight nurse team gets to a bedside and says, actually, this patient needs to be a retrieval? And that would be the exception. And that would, in general, mean you haven't done your job properly in the first place in screening them. That's probably not fair because patients' conditions change. But over the last decade, I think we've got to a point where that happens very infrequently. So a few cases. I've got 15, but we don't need to do 15. So these are all, when we first brought in the clinical prioritisation, we did some clinical triage exercises where I'd send a whole lot of these little snapshots of actual cases, usually actual cases I'd done here, out to all the SRC group and get them to prioritise it and say how they think it should be done. And we did about 8 to 10 of these exercises over a few years to try and get us, and then we discuss them to try and get us on the same page. And we've tried to go back and do them every couple of years, and I do them with the fellows. It was interesting at first. There was a widespread, and gradually we've got to be on the same page. But there's always a couple of outliers, and I suspect the outliers are influenced by their particular experiences that they've had with a single similar case. So this is, 5:30 on a weekday. You get called about someone in Auburn Theatre who's got they've come back into hospital. They had a cholecystectomy a few days before. They've come back with a biliary leak. They've gone back to theatre, had that repaired. They remain ventilated and they're going to stay ventilated and they're on some NORAD. And they're going to Westmead. So to me, this is a P3, right? So my guide is, it's in Auburn. Auburn doesn't have an ICU, so therefore my starting point is a P2. They don't need to go for anything urgently, so they're not a P1. But honestly, they're in theatres, and I don't really care if I care a bit. But if the anaesthetists have to stay around a few hours longer looking after this patient, that's still safe, right? So this patient is a P3. We don't have a road risk arm of the risk matrix of the driving conditions are really bad. So that's less of a part of this. Like, we're not asking our road teams to undertake aviation risk to get there, but nonetheless, we still want to prioritise the case and do them in a correct order. And also, it's 5:30. I wouldn't be sending a day team off to do this. I don't think it's reasonable to put a crew several hours into overtime for a patient who can stable and wait in theatres. Jackie's there shaking her head because she knows that last week she probably got sent to do this exact job at 6:30. But the aim, we try, and there are some, they're not rules, again, guidelines around what we task in the last hour or two of a shift. Second case, if Shane's online, Shane did this case. It's during the day on a Saturday. We've got a young girl in Bowral who's been accepted at Vinnie's because she's well known to Vinnie's for having a terrible cardiomyopathy. She's got a heart which just kind of flickers like this. She has to walk a lot because her soleal pump in her calves is what's circulating her blood. She's got an acute pulmonary edema. She's on a moderately high level of support with non-invasive ventilation, and she's on some inotropes. But for all of that, her numbers don't look too terrible. So I'm thinking this is someone, and part of it you get, these snapshots aren't an accurate reflection of how you do, because you're guided by a perceived level of competency of the person you're talking to on the phone and a perceived level of panic of the person you're talking to on the phone, the resources they have available to help them. But in this case, I've got someone who I think has a really significant chance of going downhill. So this is going to be a P1 or a P2, and that's going to be coloured by the other factors around there. How we do it's a challenging one because, you know, often for Bowral, if we want to get a team there as soon as possible, we'll send them by helicopter, but the transport by helicopter to St Vincent's is probably not much faster than transport by road because of the various legs involved. So that's a discussion I'm going to be having with the RLTC and the duty operations manager in the room and try and work out how best we achieve this job. And part of that's going to be impacted by asset availability. Okay, Friday night, someone's meth lab's blown up in Camp C. They've ended up in Canterbury ED and got intubated, and they're going to Concord with intubated facial burns. They're stable, ventilated. But Canterbury doesn't have an ICU. So this is a P2. They're not going to look after this patient well in ED overnight. They've got FACEM cover till about midnight. After midnight, they've got PGY3 registrars. Their anaesthetic registrars are lucky to be PGY3. So we're going to want to move this patient out. However, same patient in Westmead, different meth lab, going to Concord. Different meth lab. Yeah, different meth labs. This patient, you know, they're not going for anything urgently at Concord. So this patient's a P3. This patient can stay in Westmead all night. I'm really comfortable with this patient staying in Westmead and us not tasking a team to do this. It's 7 o'clock, so we'll try and do it in the evening. But if we've got other workload and we don't get to that patient, I can't get to that patient till after midnight, I'm really comfortable with us not getting to that patient and us leaving it in Westmead. Westmead won't be happy, and I'll have to have conversations with their intensivist, but we do that reasonably regularly. And when we brought in the idea that we weren't going to do P3s after midnight, we thought we'd get this huge backlash from facilities about not doing no ICU bed transfers after midnight. And there's only been about 2 or 3 complaints, and in exploring those, they've kind of understood our rationale. And a bit of it's influenced how we prioritise them, because I guess I had a rosier perception of emergency department staffing after midnight. But if you're not in a tertiary hospital, basically your level of registrar cover is very poor. So I'm going to be, you know, places like Sutherland and stuff have a really junior cover overnight. So I may err on the side of moving that patient just because I'm worried about how well they can be looked after overnight. This patient definitely isn't moving. So Bankstown has an ICU. It's a young woman. She's taken an overdose. Nothing to do with the meth lab fire. She would normally be accommodated at Bankstown, but they don't have an ICU bed. So she can wait till morning. That doesn't need to be done at 3 in the morning. Katie's nodding her head furiously, but also thinking, I'm sure I did this one last week. Okay, so that, and some of them, I mean, this one is the kind of job with where you think, do I need to send a retrieval team? So Hawkesbury ED, an old bloke who's got first degree AV block, but in and out of complete heart block. Yeah. Sorry? Well, he's GCS 15 without any oxygen and without any inotropes. He needs Wasn't when he had CPR. Yeah. So his heart. This is actually an easier one now. See, now I'd task an IC crew because they've got pacing as a skill. So at the time I wrote this talk, they didn't. But and that's a line ball of you put someone in an ambulance for 25 minutes, knowing they might. You know, I'm going to be guided by the fact they've responded to atropine previously. No one's going to thank me, especially the crew who are moving him aren't going to thank me if he arrests midway between Hawkesbury and Nepean when we have a team which has the equipment which can do this job. As I said, it's a bit easier now that pacing's in the ICP skill set. If I was tasking this job to an ICP crew, I'd want to have a discussion with the ICP crew about, you know, how they're going to manage it, because no one does that much pacing just to make sure they're happy with transthoracic pacing. Say this one was a little bit earlier. It's not at 7:30 at night. It's at 6:45, just before 7 o'clock. Large subdural with midline shift. Pupil still reactive, but has an expanding hematoma in their head. If orange, I'm going to task a team to do that immediately, even if it's right near the end of shift, because this is a person who needs to get to neurosurgeons urgently. And I think, you know, as a service, most of us understand that there's times when we go over because we need to do work. So the future, I just like showing old photos, but basically it shows that over, you know, the time I've been involved in the service, we've improved constantly over that time, despite my involvement. And I'd like to think we'll continue to improve. Telehealth, I reckon there's less than 10% of calls that it helps me to be able to see the patient, but there's a percentage of cases where it really helps. And sometimes it really helps to know, you know, you've got someone ringing up telling you about terrible obs. They're saying, oh, patient, you know, blood pressure's 80 on 50 and the SATs are 91%, and the clinician isn't the slightest bit worried about them. And do you think, am I talking to someone who doesn't know what they're doing, or is this patient looking a lot better than they sound? And if you put on telehealth and you see this bloke sitting having a cup of tea and reading Marty's newspaper, you know that that patient's fine for flight nurse only transfer, right? And then the converse is there'll be times when someone's really struggling and you can tell they're spiralling out of control with how they're managing a patient, and being able to see what's going on and to direct them to do things in a sequential order is really helpful. So there certainly is a place for telehealth, and it's been a great frustration that we've been unable to access it across the state because the models developed all sat within the various LHDs and they had firewalls up. So if you're outside the LHD, you couldn't see into them. But now we've got a web-based overhead camera network, which is getting us there. As I said before, having the ability to look at X-rays and CT scans across the state in real time is fantastic and really helps with, especially with those neuro patients, knowing how soon they need to go. A subarachnoid, does it have some early hydrocephalus? Is this someone who's going to drop from a GCS of 14 to a GCS of 8 very soon and therefore should be getting intubated or a team sent early? Useful things to know. It would be really helpful to be able to look at people's pathology results and read their notes, because what you get told, and then when you read you know, we've all done it. We've got told a story and then we get there and you read the notes and you find out a whole lot of extra stuff. And that happens to me as the SRC as it happens to me when I'm doing a job. Sometimes the information just doesn't get provided. So be able to read a bit more would be helpful. I touched on our interface with the regional services, which I think has room for improvement, as does our interface with NETS. At the moment, our hope is that NETS coordination is going to co-locate with us when we move to Homebush. And we've pushed really hard for that because there's been a NETS review which has suggested a bunch of changes to NETS. And I think one of the ways that could improve their coordination is to have the people doing their coordination in the same room as the people dispatching their aircraft on their jobs. And I think there's an opportunity for NETS to become more in line with the way the rest of the state coordinates and dispatches on missions, but we'll wait and see. But that's a hope and a work in progress. And as I said, similar with the regional services. A few take-home points. To my mind, definition of a mature system is one that puts the right people in place and you trust them to do their job. We do that with our registrars here. You know, we hire very skilled people to the registrar roles. Often they're not registrars. And then we put them through a really solid training program, and then we trust them to do their job. And we don't expect them to speak to a senior consultant about every job as it's going down to make decisions about where to go. They're there with a CCP who's also a very sensible person, who's hopefully a very sensible person who's been through a lot of training. And we trust them to sort a problem out with a fallback to call if they need to. So, you know, that's our model of putting the right people in place and trusting them to do their job. We need to believe that the control centre is doing the same thing. It's really easy to complain that why are they doing something this way, why are they doing something that way. Most of the time, there's really good reason for it. So we should trust our colleagues to do the job properly. At the same time, it's really important you feel empowered to ask questions. If I make a decision, I think my decisions are defensible. I've made them with a good reason. So if I'm bringing you up and tasking you on a job and it's not clear to you why you're doing it or why I've thought in a certain way, ask me. You know, it may be I haven't appropriately conveyed what my concerns are and I can make it more clear, or it may be I've missed something. I hope I haven't, but it may be that I have. So as much as I say you should trust your colleagues, you also should feel empowered to ask questions because, you know, a mature system allows both of those things to happen. And as I talked about before, you know, respond promptly. Priorities are for tasking, not for response. If you've been busy, you need to eat. Make that clear, I need to eat before I go on this job. But just because something's a P3 doesn't mean it can wait for 2 games of table tennis. Right? Most of us don't do that, but they're for tasking, not for response.
Cool questions. Anyone have any questions for our State Retrieval Consultant? Didn't get into the mind of the State Retrieval Consultant. Question from one of our visitors from Liverpool.
Thank you very much. G'day, Neil. My name is Farhad Monis. I'm one of the P1Ts, very fresh at Liverpool Station. I have a question about your comment about the clinical advice lines for paramedics, and you said it's quite dysfunctional. Like we've been in a situation just a couple of weeks ago where we had an IC, but we needed an advice just because of certain drug calculations and whatnot, even though it sounds a bit simple, but it was a bit complicated at the time. From your perspective, from a paramedic's perspective on road, how can we improve that in order to make the most out of it and not underutilize or overutilize that service?
What I think New South Wales Ambulance needs is a higher clinical level who understands the paramedic workplace, who's there for if someone doesn't, you've got a question that can't be solved within paramedic protocols. A recent call I got was paramedics turned up to a house with a lady with a busted proximal femur, which is out sideways like this. They couldn't get IV access. She'd had this leg's broken. She's had a knee replacement on this side. So they don't want to put an IO in her legs and can't get IV access. And how do we get her out? So And we just wanted to talk about, they've given I can't recall how much IM ketamine the protocol allows, but they wanted to give a much bigger dose. They wanted to talk through what are the options of getting analgesia into it, rather than just going straight to an IO. So we talked through a bigger dose of IM ketamine. I dispatched a medical team who ended up getting there. Once the patient was extricated, she got a big dose of IM ketamine and straightened her leg out. It worked really nicely. But that, if your advice line just sits within the protocols, they can't provide meaningful advice on that job. If you're a P1T ringing up the advice line, hopefully you're going to get useful advice because it's from someone at a higher clinical level. But if you're an IC, you struggle to get... There'll be times when it's good. But I just don't think it's consistently the same every day. I suspect in 2 years' time it'll be a moot point and they'll have fixed the service.
Cool. So a bit of a perspective change for ambulance as well, and that in the past it was kind of designed with protocols. So you would be functional no matter what happened. All the radio systems went down, you could work, you could function, you would be safe. So understanding that medicine is much more complicated than that, and that there are times when you need advice. You know, in hospital we would never try and do everything ourselves. Let's think about when we get some advice for the more complicated, difficult cases.
I mean, back in the day, you know, you'd ring up the hospital on the bat phone and say, can I give more Narcan? And me, not knowing you, would just say, oh, yeah, give him 10 milligrams, you'll be fine. Which I did lots of times, wasn't necessarily the right answer.
Yeah, I think just to add to that, like for you guys, just to know in the back of your minds that you can ring the SRC, that is an option. So clinical advice lines sometimes staffed by off-road managers or people who are not clinically operational, and it's a system under review, is my understanding.
Yeah.
But yeah, that you can relay that to the ICP on the scene, you know, that you can go, hey, have you thought about this as an option? Because that's always helpful.
Yeah.
We'll pitch in. I echo what both of these guys have said, but I think if you're a P1T on scene, just remember some of the best advice can come in person. So, you know, ask for a crew to back you up. Ask for a level 5 crew. If it's an ICP crew on scene with you, ask for a retrieval team. Pass a mist, ask for a retrieval team. It doesn't have to be a trauma patient. It can be a medical patient. You've got that luxury in the city. And maybe if they're not sure why you want that team, you'll get Neil give you a phone call instead of you trying to call Neil. So, yeah.
I've got a couple of questions myself. One issue is obviously the telehealth is actually very exciting because as a person who does emergency medicine, I have been almost caught out so many times by what someone's told me and then what the patient actually looks like. And it has saved my ass and patient's ass so many times being able to see the patient, not just hear on the phone or in person what they sound like.
No, I agree.
And I personally was unwilling to do the job of the State Retrieval Consultant because of my concern about the risk of trying to give advice to people who may not even have a good understanding of the patient. So it's great that there is now that facility, because I think that's going to be hugely important. But I wonder the clinical governance of that. So can you just quickly tell me about the clinical governance meetings, what you guys do, and does that also cover patient advice and retrieval advice, or is it just about triage, etc.?
It's about all facets. So jobs can get flagged. So, you know, we have a number of ways which we flag jobs. I think anyone, hopefully the message has got out. Jobs get flagged via IMS and mission debrief forms, but also, you know, the query about why did we do this job? Did it need to be this priority? Concerns around that are something we're more than happy to look into, and then I would suggest jobs get emailed to either Francis Mao or myself, and we'll look into it. And the review process is we look through the documentation and we listen to the tapes to work out, you know, because the tapes tell us a lot of stuff about information, how information was passed on and what was told. And it's interesting that people's recollection of what they were told and what the tape says is often different, that we aren't always fantastic at either imparting information, like I think I have told you something and I haven't, or the person receiving the information thinks they've received something different to what was told. So it shows why, you know, closing the loop with communication is really important, but despite that, it still gets hard. So we review the jobs, and then basically it depends what the problem is what we discuss. And the idea is to share, just like we do in Coffee and Cases and on Governance Day, share learning points around jobs. So if the same thing was to happen again or something similar, how do you approach it? How would you approach it differently? And each person can choose to take different things out of it.